I'm going to talk about chronic disease from my perspective, you know, the going through medical school, internship, community service, working all my medical career in the government sector, specializing as a specialist physician, eventually achieving my dream and running a high care unit where I thought, like, that's what I wanted. I was doing it. So I'm going to give you my perspective. I've got some colleagues here in the audience and friends. Fahima Parker, she's a geriatrician, qualified at UCT as well. Jerry Parolis, he's my partner in crime there in the emergency unit. Dr. Sasi Abdul Basit and Zahir Ghafoor. And then my husband's here as well. He runs the emergency unit in Force Bay. So we're quite surrounded by it. Very difficult to get away from it. So forgive me if I get too passionate and dive in, and stop me if I'm getting too entrenched in the details. So a little bit about me. This is my reason for living. So my husband just put the two kids to bed now and he's joined us. So I'm just showing you the various hats that I wear or have worn. At the top there, some of the nursing staff at Hassina Hospital. Always a worry for me. They're so passionate. They work night shift. They give their lives for medicine, and they struggle with their weight because it's just there's no understanding. They're the people who dress the wounds and the bed sores and wrap up the bodies of the young people. They know what it's like, you know, the obesity epidemic in our country, and they're struggling. So, you know, we've had a couple of interventions there at Hassina. Here is Jane with our Sugar-Free September, and our winner of our Sugar-Free September, who actually went off her insulin, sadly rebounded and you know, had issues again, had to get back on her insulin. Lots of, I mean, it's not an easy thing. And this is a picture from our function at Eat Better, our first function in Ocean View with Yodia and Jane. And I put this picture in for a few reasons. So do you notice the food up front there? So that's in a goodbye function for one of the staff members. That's the usual, that's the norm. I was looking for pictures to kind of give you an idea of my life, and I realized I had no pictures. You know, that's just the nature of it. And you know, the reason I put this picture up is because these people that are standing there with me are people that have molded me, have shaped my life, shaped my career. I truly respect them. You know, the slide that's next is about what it's really like to be a doctor in tertiary South Africa. Doctors that I know a lot of doctors who become flippant and blasé, but the doctors I know are caring people, passionate people, altruistic, going into medicine to truly make a difference, giving of themselves, sleep and crying tears when you lose patients. These are the people I know. These are the people that I've worked with. These are the people that I respect. You know, these are the people. So I want you to also understand that there's a lot of stuff that I believed, I practiced, low fat and all of that, that was just the norm. You never stopped to think about it, you just did. And the problem is that there's so much passion, there's so much change that people want to make, but we are being crippled by the number of patients coming in with not just obesity, not just diabetes, there's also the HIV epidemic, there's the trauma epidemic, you know, and so it's an onslaught, and at some point you become a pill pusher. At some point it's surgery or a pill. You actually, that's the best you can do. I've stopped clinics that have had 60 patients waiting. When I see a patient, this was before my banting days, I've always been passionate about diet, and I've stopped seeing this patient 130 kilos and took an hour to say, well, what do you eat? Let's just stop here, tell me what you eat. And he was having like 8 liters of Coke, 10 liters of Coke a day, 3 loaves of bread, you know, I mean, and he's like, I'm always hungry. And I said, well, you got to stop. You know, you stop the drinks. And I happened to see him about a year later. I mean, he'd lost about 15 kilos. You know, he wasn't banting. I didn't know anything about banting back then. But, you know, it's an onslaught. So I just wanted to share that with you, where I'm coming from, that There's a great need, and this is why the Nutrition Network is so important, because there are lots of doctors who are interested. There are actually lots of doctors who bant, believe it or not. They may not tell you, but they bant. And you know how you see it? You suddenly, they lose weight, but you look at their faces and there's this vitality. And you stop them. I've stopped them in the corridor. I'm like, so you're banting? They're like, yeah. But, you know, anyway. So I wanted to share a little bit about my journey with you. So I reached the pinnacle. I was living the dream. The house, the wonderful husband, the 2 children, you know, a specialist physician running my thing, and I was miserable. And I was like, what is going on with me? I am miserable. I was snapping up my children, leaving home, driving the 1.5 hours to critical care hospital, blah, blah, blah. I'm going to share this poem that came at a point in my life that was quite, I was probably at the lowest point in my life, and I started a blog called Carb Free MD, where I shared this journey. And this is my poem that I worked on for weeks and weeks, and I wanted it to start my blog with this. Morning rounds in the high care unit in the HCU. Good morning, Mrs. X. How are you? Mrs. X looks vacant, craving a smoke, diabetes, hypertension, and now a stroke. Mr. Y, Miss Z, Mr. ABC, Mr. Heart Attack at 30, can't wait to be free. Wife and children wide-eyed, afraid. When can he come home? What changes can be made? Too late, too much sugar on your plate. Can't turn back the clock, Grim Reaper awaits. You take your last breath, you are finally free. So tragic, this loss. How different it could be. It still makes me very, very emotional. I've had my hand inside a patient's abdomen. A breathing, living human being, obese, lying on his tummy. I've had my hand in his back, his skin necrosed from diabetes. I can't tell you how many people I've had to break the bad news to in the high care unit. Young children grieving over, coming in with their Coke and their chips, obese already, young wives, 20s, not 30s or 40s, 20s. So a colleague of mine asked me why I'd made this change. This is why. Because I am sick and tired of standing, catching people at the very end. The change needs to come way before. So I changed my profession. I quit. And it was the most difficult but the most liberating thing for me. And I had to share this with you because I need you to know how devastating it is to live this life. We see it. We see the people out of the 10 beds in our high care unit. Sometimes 10 out of 10 were patients with myocardial infarctions ranging from the ages of 20 odd to 60s. I mean, Jerry still does that job. He'll tell you that's exactly how it is. Fahim has done that. That's the reality. So I also want to share with you kind of a good news scenario, not really. So Jude. So every day in the high care unit you would get one DKA, at least one a day. So the problem with the DKAs, especially the young ones, is it is so difficult to get them to change their mindset. By the time they come to you, they've already been on whatever low carb stuff, insulin, and they just, woe is me, I'm a victim in this. So Jude, handsome young man, comes in at least once a month, every second month maybe, with DKA. So if you leave him in a day or so, he would die. So it's dire straits. Comatose, put up the lines, blah, blah, blah. The next day, he's kind of awake again. And it's the same story. What's going on? Oh no, I didn't take my insulin, I had cake, da, 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 you know. And I would stop the round and I would give this lecture. And everybody knew, and nurses started panting. But he just would not. Yes, doc. Yes, doc. No, no, no. I learned my lesson, doc. He'll be back in a month. It happened, it happened, it happened. I never gave up. And then one day he came in with a stroke. And I saw him and my heart broke. And he was like, oh, doc. He couldn't speak. He couldn't move. And I just took a deep breath and I walked away because it felt to me like it was over. So a couple months later, he was admitted. I saw him in the corridor. And I also ran the low care unit. So he ended up in the low care side. And I said, walked past his bed and there was a banana. And I said, don't eat that banana. And he goes, no, I'm not eating it. You see, they gave it to me. And he was like, still not eating it. Still can't speak properly because of his stroke. And he said, I said, huh? He said, I started banting. I said, what? I looked through his charts. He used to come in with insulin like 60 units a day, like 30, 20, you know, and still high sugars. You know how much insulin he was using? 2 units. 2 units of insulin, type 1 diabetic. I said, what happened? He said, my sister got a hold of me. It took a long time for him to explain. My sister got a hold of me. She said, this is it. You are starting that Dr. Tim Noakes diet. You're starting that diet. She sorted him out. So it wasn't me. It was his family. It was Prof. It was Prof making the big noise. Somebody listened. You know, I've seen him subsequently. He still has a little bit of, you know, who knows what, there's damage to the kidneys, there's damage to the eyes, you can see it. But this is just to show you, if you catch it early, you've passed your oral glucose tolerance test. Are you safe? So who knows what an oral glucose tolerance test is? Okay, so I'll just explain briefly. They basically want to check whether you're pre-diabetic or you're diabetic. Actually, they just want to check if you're diabetic, right? Because what's the advice that we give? You need to change your diet. Next patient. Dietitian. You know what the problem is that there's so many obese patients that, I swear to you, in a secondary level hospital that I worked at, I could not get obese patients referred to the dietitian. She said, is it an obese patient? Sorry, I just don't have room to see obese patients. I will bring them a diet sheet. Then there were no diet sheets because the staff was so desperate to lose weight that they would take all the diet sheets home. So then there were no diet sheets. So the oral glucose tolerance test, they give you 75 grams of glucose and then they measure your glucose after 1 hour and after 2 hours. And it's simple. If you're over 7, you're fasting, you're diabetic. If you're over 11 after 2 hours, you're diabetic, right? So you are overweight, you get told, oh, you must go check for glucose, you do your test. No, you're fine. Your level is 7 or something, like 6 something. You're fine. You're not fine. So look at this slide. Don't focus on the details. I'm going to show you. I want you to look at this line and that line, right? So this is glucose. So here, everything is hunky-dory. So this is in an insulin-resistant person. I want you to imagine this. You eat cereal. Your glucose spikes. Your pancreas, imagine it's a factory working overtime, churning out insulin. You bring, your pancreas goes, whoop, oh, bring down the glucose. Insulin, right? You have a muffin, a Coke, glucose, insulin, whoop, insulin. What's happening? Insulin, insulin, insulin. That poor factory has no time to, those workers in the factory have no time to rest, okay? So they get no weekends off. Then you say, okay, no annual leave. Then, oh, no Christmas, oh, no Easter. And they're like, what? So what's happening here? Here's your glucose, here's your insulin, trying really, really hard. Our bodies perform the best, at the best level that it can to keep us alive. That's what we're all, our bodies are working really, really hard just to keep us alive. So here's insulin, right? Suddenly, pancreas says, can't do this anymore. What happens? Your beta cells, the cells that produce insulin, start dying. What happens to your sugar? It starts rising. Now, what happens here? This is where the glucose tolerance test misses you completely. You look sick. You look in the mirror. You walk, you see the lines at Cinnabon. You do not look healthy. But the test says you're fine. And so what happens? No, I'm healthy, my ECG was fine, my sugar's fine. Do you see how backwards we've got it? So this man, I'm going to go really quickly now, this man is Dr. Kraft. In the 1970s to the 1980s, he said, he's a pathologist. He studied person after person after person, cut up their bodies, and he found diabetes, he says, is a disease of the vessels. It's not a disease, it's not what everyone's talking about. It's not just about the insulin and the pancreas, it's a disease of the vessels. So what did he do? He said, this is not the way I'm going to do glucose tolerance testing. He didn't stop at 2 hours, he went as far as 5 hours. He tested over 14,000 people between the ages of 3 and 90 odd. And he discovered, he's written this book called Diabetes Epidemic in You. So it's something that you can try and get your hands on. There's a Kindle version that's out. So don't focus on these graphs at all. All I want to show you is the variation. So this is the healthy pattern where you see that your insulin level, so he took insulin and glucose and he did it at half an hour, 1 hour, 2 hours, 3 hours, 4 hours, 5 hours. And he plotted all of these people and he found the normal and the abnormal. So the normal, so if you look here, out of 10,829 people who were told that their glucose tolerance test was normal, only 2,000 of those were truly normal. He coined a term, diabetes in situ, which means it's going to happen, it's coming to get you. It may not happen right now, it may come in a month or a year or 2 years, but it's coming. You're not diabetes free, right? So this is healthy. Pattern 1. Now I'm just quickly going to go through pattern 2 is that curve. Look how different it is to pattern 1. So this is about insulin. This is your insulin secretion to a glucose load. So what's happening is it's peaking later and this peak is still at 1 hour and it's taking a long time to come down to normal. That means that you're churning out insulin, you're struggling to bring it down. Next pattern, same thing there, pattern 3, it's a delayed peak and a delayed return to fasting. Pattern 4, delayed peak, delayed return to fasting. And then pattern 5 was a low hypoinsulin. So what he then did was he took patients, and so this is a very bad slide, but the best I could find. That's the way the person presented. He was a pattern 3. He put him on a low carb diet, and look what happened to his pattern. That's insulin. Insulin levels go down. I mean, it's now common sense. It should be common sense, right? So this is a letter that he wrote to Prof. Grant Schofield in New Zealand. And look what he says here. What he talks about is he says that he's published all these studies in the 1970s already. It's bigger than an epidemic. And he says the earliest diagnosis with treatment will abort the worldwide epidemic of diabetes, which continues to impound national and international medicine. Hypoglycemia for many unfortunately remains the earliest diagnosis for diabetes. We need to get it earlier. So there are other tests that I'm not going to go into them, but there's a HOMA IR. I don't know if you use it. So if your cutoff is over 2.6, I'm just telling you what's out there so that you can ask your doctor to do it. So it's basically your fasting glucose times your insulin over 22.5. If your doctor doesn't know about it, there's an MD calc that you can get on your phone, and all he does is puts in your numbers and you can see what the cutoff is. I'm going to talk a little bit about insulin. So this is what insulin does in your body. We mostly think that insulin is all about bringing your sugar down, but insulin affects cells throughout the body, predominantly the blood vessels. And where do we have blood vessels? Everywhere, right? So here's your insulin receptor. It's not a simple thing. So your insulin is released in response to a glucose load. It attaches to the molecule. A lot of talking happens here. Here's your glucose receptor that needs to now catch the glucose and bring it into the cell. It translocates to the top of the cell, and glucose gates are open. Glucose can now enter the cell. That's just the normal. If your sugar is more than 5, this happens. If it's not, then you've got the other pathway of glucagon. I'm not going to go into the details. I just want to teach you a little bit about how devastating hyperinsulinemia can be. This is basically another pathway that shows you how insulin affects all cells. So it's the pancreas, the liver. I wanted to stop at this slide to show you all the different effects that insulin has all over the body. So what's the big deal with insulin? Impaired insulin signaling is central to the development of metabolic syndrome. Now this is something that the physicians in the audience, this is a common sign. Please go home, look at your partners, look at your family. I'm being serious. This is something that's called acanthosis nigricans, okay? At this stage, you've had hyperinsulinemia for ages. What happens here is that your insulin receptor actually causes, that's your skin cells, it binds and causes your skin cells to proliferate. So if it's doing that on the outside, it's doing that on the inside, okay? This is very important, hypertension and insulin. Insulin, when you're insulin resistant, so the effect that insulin can have, don't worry about the detail, but I want to show, especially for the doctors in the audience, stimulates endothelin-1, which is a potent vasoconstrictor, okay? It causes the volume of the blood to go up. You know, it's causing hypertension. It causes sympathetic, so your adrenaline starts pumping. It causes hypertension. You cut down the insulin, the hypertension goes away, okay? Another thing about inflammation, it stimulates inflammation in the body. So it's basically calling a cry for help. Help, send me the inflammatory cells. I need help, something's going on. The inflammatory cells come, what is their job? Their job is to destroy. They start destroying at the blood vessel level, okay? Everybody knows about PCOS. What's happening in PCOS? Insulin sits in the receptor. There's insulin-like growth factor. It causes your theca cells in your ovaries to proliferate, making more male hormones so you don't ovulate. You take the insulin away, you ovulate. Rita, how many people have fallen pregnant on Banting 7-day meal plans? So, you know, insulin also acts in the brain. It's supposed to tell the hypothalamus, stop, you know, vagal nerve, I'm full, stop eating. But when you've got hyperinsulinemia, that doesn't happen anymore. Okay, so I just wanted to share with you how devastating the effects of insulin is. It's not just about sugar, it is throughout the body. And it happens way before we see the effect. If you've got diabetes in your family, if you're gaining weight, you're most likely insulin resistant. You know, start cutting out all the sugars from eat whole foods. So metabolic syndrome is something that's diagnosed. It's hypertension, impaired glucose, to waist circumference going up, impaired triglycerides, and if you've got 3 out of 5, you have metabolic syndrome. What's the problem with metabolic syndrome? Well, there are 2 studies I'm going to show you, both locally in South Africa, where they found, this was somewhere in the Boland, where they found 46% of the women had metabolic syndrome. This was one in Umtata on adolescents, 13 to 18. 13 to 18, 47% of the girls had metabolic syndrome. It's the first time that children are not going to outlive their parents. It's devastating. Okay, we've got hypertension clubs at the day hospital, we've got diabetes clubs, we've got coronary artery disease clubs. You know, it's overwhelming. And what is the problem? What is metabolic syndrome? It puts you at risk for stroke, PCOS, cancer, cardiovascular disease, type 2 diabetes, non-alcoholic hepatitis, so hepatitis from fat being in your liver. Okay, and I just want to show you this slide. What does metabolic syndrome cause? All of those things. What does the LCHF diet do? It takes away all of those things. And we've seen it. And there's a beautiful study that you can read about that summarizes it beautifully. It's Prof's study. So how do you make chronic disease disappear? It is simple. Reduce your insulin dramatically. How? Low carb food. What do you use? Do you wean? What type of person are you? Are you the wean? Know yourself. Is it going to work if you wean slowly, 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 and then you stop? Or Band-Aid approach? Figure out who you are. Be prepared. Shop adequately. Have the types of food in your house that when you're hungry, you're going to go for the right thing. You know, make a conscious decision. Feed your children whole food as much as possible. How much sugar is in your food? Know the sugar content. How much is in a banana? How much is in an apple? How much is in a muffin? Don't eat the muffin. There's so many other awesome low-carb muffins you can have if you need it. Okay? Know the names of sugar. My sister, my family came down to visit. They started to band. And my sister was like, and I got my coconut sugar. Coconut sugar is sugar. Okay, so what's tripping us up? Blasé attitude. We've got our memory is not great. We're used to, there's no giraffe epidemic of obesity. You don't see zebras getting bigger and bigger and bigger. If not, National Geographic would be here. But we see it. We see it everywhere, and we just don't bat an eyelid anymore, okay? Socially, we're too polite to say no thank you. Endless bloody birthday parties at school. My goodness, every week there's Baker Man on a Friday and 20 class parties. Boycott that. Be the change. The grocery store specials, the victim mentality. You know, you eat your feelings. Figure out what's eating you. Change your story, change your health. Thank you very much.